All right, everybody. Thanks for attending the Tuesday night webinar. Uh, Last week, I talked about leading the pack, stop following the followers. And one of the things that I wanted to say about this is, when it comes to your marketing, what are you actually doing when it comes to marketing? Today, I went to the TV station and shot 12 1 minute, what I call the medical minute commercials. And guess what? It wasn't on. It wasn't on knee pain, and it wasn't on peripheral neuropathy. It was actually on my second book, and that is Highway to Health: Depression, Anxiety, Insomnia, and Chronic Pain Syndrome. So, it's. I think everybody's kind of beat up the peripheral neuropathy niche, if you will. And I just want to say too that if you're, doing peripheral neuropathy and you're not treating the metabolic side of it, you and I need to have a conversation, because if you're just treating, the doing lasers and other types of stimulation, you may not be serving the patient to the highest level possible. And what we do in our clinic is 99% of the time, we're always looking at a person from a neurological standpoint, a metabolic standpoint, and a regenerative medicine standpoint. So today, what we want to talk about is we're going to be talking about median nerve entrapment. And before we get started, I wanted to say here in Tupelo, I have my module 3 coming up next weekend. So if you're not already registered, you probably won't be attending. But talking about, niches, what about movement disorders, Parkinsonism, early onset Alzheimer's, dementia, those kind of things. These are the things that very few doctors are going to be able to teach you, because I'm a board certified chiropractic neurologist, and I carry a fellowship in functional neurology as well. And I've even written a book on this. And so again, it's you want niches, I can give you niches. And the wave of the future is going to be in brain-based disorders. And I've got a seminar coming up this weekend in Tupelo with brain-based disorders, movement disorders, Parkinsonism, and early onset Alzheimer's. And if you go to barlowbrainandbody.com and you click on courses, you can see that I don't know what I'm doing on here, schedule. And then in Conroe, Texas, May the 20th through the 22nd, I'm going to be giving my Neural Reconnect. And this one is actually going to be my upper extremity frozen shoulder seminar. I will be dealing with neck, frozen shoulder, and the entrapment syndromes in the hand. And that's what we're going to talk about a little bit tonight, is carpal tunnel syndrome. And how do we look at this? So one of the first things I want to say is never take the patient at their word when they say they have carpal tunnel syndrome. Very, very seldom do I see a patient who has says they have carpal tunnel syndrome that actually has carpal tunnel syndrome, because they think that anything that's, if their hand is numb, any part of their hand, they think it's carpal tunnel syndrome. And the reality of it is, if we have carpal tunnel syndrome, what we have is we have the thumb and the index finger. This is actually median nerve C6. And then the middle finger is median nerve C7. So if they come in and go, my entire hand is numb, that is not carpal tunnel syndrome. So we may have a plexopathy. We may have probably not multiple peripheral nerves entrapment. We probably have plexopathy, or this is the blinky light, and we come over here and do a neurological exam on this hand, and this is numb as this one. So again, I don't really pay that much attention to the blinky light, because most of the people that I market to have chronic problems. They almost all do, which means that they have a neurological, a metabolic, and some type of regenerative care that they need to actually maximize their recovery. But tonight we're going to talk about carpal tunnel syndrome. So if you have any questions, just type them in, or we can get to them at the end. So here we go. We're going to hit this a little bit this weekend at my seminars, just briefly, because I'm giving a 20-hour seminar on this in Conroe, Texas, in May. So if we draw this out, we have C5, C6, C7, C8, and T1. This is our area of the brachial plexus. These are the actual nerve roots. So, and this is the way that I draw it, is that we take a Y and we draw a tail and a Y. And please forgive me, I still got patients in the clinic. So if you hear people and there it's patients that we still have. So a Y and a tail and a Y, use your imagination, and a Y and a tail. Let me get out of this just a second. All right, and then a Y and a tail. So, and then we're going to draw an X and a Y. This is our divisions, okay? And then the next thing we would do is there's going to be 4 sets of 3 that we're going to draw out. So here, right off the nerve root is 1, 2, 3. And then the posterior cord, we have 3. And then on the medial cord, we're going to have 3. And then here we have 3 nerves that come right off the nerve root. All right. So here we actually have to name these. I'm going to go through them quickly because this is recorded. This is our dorsal scapular nerve, and this dorsal scapular nerve comes right off C5 nerve root, and it actually had to do with our rhomboids. So when people have whiplash injuries, car crashes, that C5 is almost always the one area that's damaged. C5 controls all the muscles in the shoulder except 3, and they control our rhomboids. So when I see people who have C5 problems, or somebody who comes in and they have a blinky light of, they have shoulder problems or neck problems, I want to ask them about their rhomboids. If they have neck problems, I want to ask them about their shoulder. If they come in with shoulder, irregardless if they have neck pain, I'm going to say, tell me about your neck pain, and I want to know about your rhomboids. Does it feel like the weight of the world is on the back of your shoulders? And the answer usually is yes. So this is how I get people to understand that I know more than just a blinky light, because I understand the neurology behind what's going on just from a C5 standpoint. Suprascapular nerve, this controls our supraspinatus and infraspinatus. I don't have time to go into that great detail with that, but it's the first 15 degrees of abduction and external rotation. Lateral pectoral nerve from C7. These are our pec major. We have the upper branch of the subscapular nerve, which is our subscapularis. The thoracodorsal, latissimus dorsi, lower branch of the subscapular nerve, and this is our teres major. Again, I'm just going through all of these. I'll discuss this a little bit in detail this coming weekend at my seminar and at Conroe, Texas. We're going to draw all of this out. We're going to talk about how the muscle spindles, Golgi tendon organs, how they fire into the cerebellum, brainstem, and how it affects focus, attention, concentration, all kind of things, not just simple frozen shoulder syndrome. Long thoracic nerve, serratus anterior. Then we have the medial pectoral nerve. This controls our pec minor, median cutaneous nerve of the arm, and median cutaneous nerve of the forearm. And this is exactly like its name implies, median cutaneous nerve of the arm and into the forearm. Now, as we get to the median nerve, which is the seminar tonight, or webinar, we take the lateral cord, the medial cord, it comes together and makes the median nerve. Now here we have the musculocutaneous nerve that controls our biceps, long head and short head. We have the axillary nerve, which can become entrapped. This controls all of our deltoids and our teres minor, radial nerve. This nerve actually has 3 areas that it can actually be entrapped along its neurological pathway to the terminal end, but this is radial nerve controls all of our extensor muscles. Then here we have the median nerve. It has like all the peripheral nerves in the upper extremity. Well, when I say all, I mean radial nerve and ulnar nerve. They actually have 3 areas in which they can be entrapped. And then we have the ulnar nerve. So let me just reiterate this. The brachial plexus, when you have a plexopathy, there's 3 different areas in which we can have those entrapments for the plexopathy, but it's real simple. If somebody comes in and they go, I've got shoulder problems, and it's going all the way down into my hands, it's either a metabolic problem, a dorsal column problem, or we've got a plexopathy, and that's your job as a doctor to figure that out, okay? And more than likely, if they come in with chronic health problems, it's going to be metabolic disorders and something else. So that's the thing I want you to get wrapped around your head. If they're suffering with metabolic disorders, chronic disorders, it's going to be metabolic plus neurological. And then you, as a doctor, you've got to use your clinical skills and this differential diagnosis to determine, is this a plexopathy or do we have a plexopathy plus metabolic? And then what area is this entrapped? So again, if it's a plexopathy, we're going to have problems shoulder, and then all the 3 peripheral nerves in our arm, radial, median, and ulnar. So we're going to talk about the median nerve. So we're going to go to another screen here. And please forgive me because I've just had had somebody come in and have to redo all of this, and it's anyway, it's what it is. So median nerve. So here we go. Median nerve in the arm. Okay, it just passes through. So the median nerve just passes through our arm. Okay, and then once it gets to the elbow, the first level of entrapment is going to be what is called the ligament of Struthers. I want you to know that it's there just in case. In 20 years, I've actually had this as a problem. Okay, how do we know that ligament of Struthers is damaged or causing an entrapment? It means that everything distal to this is going to be weak. Okay, and we're going to draw this out right here. So at the elbow, the ligament of Struthers is weak or damaged. And the way we would treat this ligament of Struthers, that it's not a torn ligament, which they would know on an MRI. And what we're going to do is shock wave. We can also do regenerative medicine if you want to do that, but we can also do laser. So I would probably recommend all three of those. But again, I'm not in your clinic, and I didn't do an exam on this patient. I'm just giving you some options. But again, we're talking about one patient in 20 years. So I really talk more about this than what I'd like to, because I'm just not going to see it that much. All right, at the elbow, excuse me, at the elbow, we have a nerve that comes off that's called our anterior interosseous nerve. This nerve is purely motor, purely motor. Now, this anterior interosseous is going to, this nerve goes to our flexor pollicis longus. I can spell longus. All right, flexor pollicis longus. This is our cigar lighter. So if you smoke cigars, you definitely need that thumb doing that. So light your torch. Okay. I've actually seen this one time in my 20 years of practice. So again, I don't see the anterior interosseous nerve being entrapped a lot, but we need to know what's going on here. Then we have the flexor flexor digitorum, excuse me, profundus. All right, and this is where we get the distal end of the digits here, that flex, and then the pronator quadratus. And what the pronator quadratus does, it actually allows our arm to pronate at any angle. All right, the pronator teres, its optimal pronation is going to be at 90 degrees. Now, this is the next area of entrapment. It's going to be the pronator teres syndrome. This is going to be the most common. So if you want to know what's going to be the most common area of entrapment, is going to be the pronator teres, aka pronator teres syndrome. Okay. All right, pronator teres. Now, here with this, we have three other nerves. It's called the flexor. I'm sorry, I said nerve, I meant muscle. Flexor digitorum superficialis. The reason I don't like the way this screen is set up is you actually have to take your pen completely off the screen, or it kind of drags it. So, so the flexor digitorum superficialis is flexing the proximal aspect of your fingers. And again, just letting you know it's here. The major problem here is going to be our pronator teres. And then another muscle that comes off here is going to be our flexor digitorum, flexor digitorum radialis. Get it right in a minute. All right. So again, just flexes your arm. I'll get it right. So I'm sorry. Flexor carpi radialis. Flexor carpi radialis. So flexor carpi radialis, doing this muscle right, this movement here. So at this point, we've got two areas of entrapment. Ligament of the Struthers. So if this is entrapped, everything downstream from it is going to you're going to have neurological symptoms, like the muscles are going to be weak and sensory deficit. Pronator teres, everything distal to this, we're going to have a problem. Remember, the pronator teres is the #1 area of entrapment. Let's move on. All right, now after we get past the pronator teres, we're going to have a cutaneous nerve, and this is what allows us to differentially diagnose this. All right, is this cutaneous nerve that comes off before the carpal tunnel. So here we have this is our hand, this is our flexor retinaculum right here, this vertical line. Once we get past the flexor retinaculum, we have a motor component, and then we have another sensory component. So let's talk about this just a second. So we're going to talk about the the lateral aspect of the hand. We're in, excuse me just a second, drop the pen. we are in an anatomical position, okay, anatomical position for the lateral aspect here. So let's look at the hand. There are going to be 4 areas in the palm that have cutaneous distribution, all right? Now, don't make this any harder than it is. This is the median side. This is the median nerve. Remember, median nerve C6, median nerve C6, C7. This is the ulnar nerve. Look at this. You know, this is our neurology gang signs here. This looks like an M, and this looks like a U, all right? So if you do this, and that's an M, this side here, this is our median nerve, ulnar nerve, all right? So we take this into 4 quadrants. The quadrants here, these are called our palmar distribution, okay? The palmar aspect always goes over a tunnel, all right? So if it's in this distribution here, it goes over a tunnel. This is our median palmar cutaneous nerve. This is our ulnar palmar cutaneous nerve. Can't hardly say that tonight. This is our median superficial cutaneous nerve, ulnar superficial cutaneous nerve. The superficial nerves go through a tunnel, all right? The palmar aspects, they do not go through a tunnel. It means they go over the tunnel, just like we've drawn right here. So let me just write out the muscles here. So there's 3 muscles in the thumb that we can test for median nerve. The first one is going to be our abductor pollicis brevis. All right, so what this does is, can you bring your thumb up like this? All right, you bring it up like that. The next nerve is that's going to come off here is our condensed pollicis. All right, so this kind of goes in line with that abductor. Did I say abductor? Yes, I did. Abductor right here, and then opponens is going to. When you bring your little finger together, it looks like an O. So the opponent. And for just so that you understand this, when I bring in my little finger, this is the ulnar nerve. When I bring in my thumb in this direction, this is the median nerve. But they both make the opponent's function. And then we have the third muscle, which is our flexor pollicis brevis. And the reason I don't really test this one is because this one here, when you just drag your finger across here, this has dual innervation with the ulnar nerve. So again, if the median nerve is weak, then you still, since it's dual innervation, this muscle can still be strong. So those are the 2 muscles we're going to test, is the abductor pollicis and then the opponents. How do we differentially diagnose this? If we look at this pronator teres right here, and I wrote down number 1, okay, what will happen in this situation, we're going to lose this palmar median cutaneous nerve that goes over the carpal tunnel or the flexor retinaculum. So the way we're going to do this, patient comes into the clinic and they go, I only have numbness in these 3 digits. So now what we have to do is we have to find out, do they have carpal tunnel syndrome or do they have pronator teres syndrome? Irregardless of which one they have, we still have a neurological treatment system called Neural Reconnect that actually can solve this problem. But we have to know anatomy, because if you don't know anatomy, you can't play the game. If you don't know the entrapment sites, you can't play the game. So you're just over here just pounding down high spots or whatever. All right, you're just adjusting the neck to treat a carpal tunnel syndrome, and the pronator teres entrapped. It's not a neck problem in this scenario. So what we would do is get a cotton ball. So with a cotton ball, we're going to test our forehead. And we're going to say, does this feel the same as this? Yes, it does. Remember, the symptom is in this finger, in this hand. Does this feel the same as this? Yes, it does. Does this and this left hand thenar feel the same? Yes. This thenar, this V1, V2, okay, feels the same. And then we come over here with the cotton ball and we stroke the thenar, and they go, nope, I can hardly feel that. So what happens here, if they go, I can hardly feel that, what this means is that the pronator teres is actually entrapping the median nerve, because this median nerve here, see this palmar median cutaneous nerve, it actually goes over the tunnel, not through the tunnel. So if we have median nerve entrapment back here, then we're going to lose this thenar sensation. If it is true carpal tunnel syndrome, then what will happen is this area, this palmar median cutaneous nerve, will be preserved. So here, let's see if I can kind of, right here, this area is entrapped, okay? We see that the palmar median cutaneous nerve goes over the tunnel, so If we have the entrapment at the flexor retinaculum, this area right here will actually be preserved. Okay, and we'll just have numbness and tingling in these 3 digits. So again, cotton ball, you don't have cotton ball, use a tissue paper. And all we have to do, the patient comes in and they have numbness in this hand. I cannot honestly tell you the last time someone came in with true carpal tunnel syndrome. It's been almost always the plexopathy, metabolic problems. They have numbness in the entire hand. They'll say, I got carpal tunnel syndrome. Show me, take your finger and show me where the problem is. It's like it's all over my hand. That's not carpal tunnel. All right. So we're going to keep it simple today and say they come in and truly these 3 digits are the only thing in their body that's having a symptom. You've done a neurological exam, everything is good. Boom, right here. All right. Now we need to know, do they have ligament of Struthers? And all you have to do is go, well, I remember Barlow saying once in 20 years he had that. How do we know if we have that? The pronator is going to be weak. Right here, boom, pronator is going to be weak. If the pronator teres syndrome, the pronator will actually be strong. That's important. Pronator teres is going to be strong. The muscles in the thumb will be weak, and we're going to have sensory deficit here. So we'll take a cotton ball. Does this feel the same as this? Yes, it does. Does this feel the same as this? Okay, yes. Does this thenar feel the same as that one? And they're going to, if it's a pronator teres entrapment, they're going to say, I can hardly feel this sensation right here. So you better be working here on the pronator teres because that's where the problem is. Shock wave, laser, activating the Golgi tendon organs for releasing that entrapment site. And I'm going to be going over that next month in Conroe, Texas. If you go, does this feel the same as this? Yes, it does. Does this, the good side, feel the same as that? Yes, it does. Does this feel the same as that? And they go, yep, that feels exactly like that, but I've got numbness in my fingers. We know that the problem is right here at the carpal tunnel because the palmar aspect of the median nerve is preserved. The superficial branch here is not intact. So hopefully we've gone over some very useful, I hate wasting time and I don't want to go over information that's not useful, but hopefully we're able to go the next time somebody comes into the clinic, do they have a plexopathy, shoulder, elbow, hand, something's wrong there? Okay. If they just say my hand's a problem, take your pointy finger out and show me where it is. And if they go my front and back of my hand, it's not carpal tunnel, it's got to be this. And so once we come in here, then we know that there's only 3 areas that can be entrapped: ligament of Struthers, pronator teres, or carpal tunnel. Okay. And so we went over that today, and I want to open up anything for any questions that somebody has. I will be going through this in detail this weekend. I know some people came in late tonight for the webinar, and that's cool because it's going to be recorded. But I do want to say that coming up next weekend in Tupelo, Mississippi, I'm going to be giving my level 4, and this is going to be on movement disorders, Parkinsonism, early onset Alzheimer's. And again, I had a lady, I'm going to close with this, and I'll give you guys a second pipe in with any questions you might have. Lady comes in last week, I think she was 46 years old, come in with more like fibromyalgia symptoms. And see, you've got to stop looking at the blinky light. Now, I know some of you probably deal with acute patients. I don't market to acute patients. Actually, matter of fact, today we referred a patient out to another chiropractor. They came in and it was, acute problems. You're in the wrong place. It's like, we need to refer you to another chiropractor in town. So movement disorders, early onset Parkinsonism, early onset Alzheimer's. The patient came in 46 years old. I linked her, fibromyalgia pain. Tell me about your focus, attention, and concentration. And she had focus, attention, and concentration issues. And I said, do you walk into a room and forget why you walked in there? And I go, bam, you're already in stage 3 dementia right now. And talk about getting their attention. And this is a $15,961 program. So we have who can see about the messages, and then I don't know what that question is right there. So anyway, I've got just a couple of minutes to go, and I'm going to be, we actually have this set up where it automatically shuts off at a certain time so that I will make sure that I speed up, get things done, get to the point. So if you do have any questions, we do have a couple of minutes left, and I'll open up. You'll have to unmute yourself, so please ask any questions that you have.
I don't have any questions here yet. I just have a comment that said that they love the way you described the gang signs. So
the which one?
Your gang signs, I guess.
Oh yeah. Hey man,
your ulnar and media.
I mean, in Mississippi, we're notorious, especially the northeast side of Mississippi. We're just notorious for gang banging. So you got to mix with the crowd. So so anyway, I wanted to thank Randall for putting this on. JT and Linda, it's always great to see you guys on here. Shelly, Brad, Chris, Rom, good to see you, brother. And if I missed anybody, I'm sorry. I just see a couple of names that's up here. And I want to thank everybody. And Randall, again, I want to thank you for putting this on. And I will see you guys next Tuesday. And y'all have a great week and go change people's lives.